Substance, medication-induced psychotic disorder. Background: 25-year-old single unemployed white male who is being seen by a psychiatrist for several years for management of psychosis, depression, anxiety, and abuse of marijuana and alcohol. At age 15, he began to show a dysphoric mood, anhedonia, low energy, and social isolation. And at that same time, he started smoking marijuana and consuming alcohol daily. He developed episodes of depression associated with sadness, irritability, amotivation, panic attacks, and showed a decline in school performance. Sertraline 100 milligrams daily was started along with psychotherapy, and he generally appeared sad, irritable, and amotivated. At age 20, he developed a psychotic episode with hallucinations and delusions with suicidal ideations that warranted an inpatient psychiatric hospitalization. He developed depression, anxiety, a decreased appetite, decrease in concentration, and suicidal ideations. Dysphoria, irritability, and amotivation persist despite antidepressant and antipsychotic regimen. Hallucinations and delusions subsided with adherence to antipsychotic clozapine. He smoked several marijuana joints almost daily and binge drinks on the weekend with occasional blackouts. Psychotic features continued until age 22. At age 23, he attended AA and NA and achieved sobriety for 2 years. DSM diagnostic criteria for substance medication-induced psychotic disorder. Presence of one or both hallucinations and/or delusions, evidence from the history that symptoms develop soon after substance intoxication withdrawal or after exposure to a medication. The involved substance is capable of producing the symptoms. The disturbance is not better explained by a psychotic disorder that is not substance-induced. The disturbance does not occur exclusively during delirium. The disturbance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. Rationale for diagnosis. Mr. Evans started developing symptoms at the same time he began drinking alcohol and using marijuana, which included dysphoric mood, anhedonia, social isolation, sadness and/or irritability, amotivation, panic attacks, poor concentration and school performance. Symptoms that develop with continued heavy use of alcohol and cannabis include persecutory delusions, auditory hallucinations, depression, decreased appetite and concentration, suicide attempt, dysphoria, irritability, and amotivation continued. Rationale for diagnosis. After continued heavy use of cannabis and alcohol, Mr. Evans developed hallucinations and delusions, which are the hallmark of psychosis. Clinical features of schizophrenia and cannabis abuse show overlapping characteristics. However, cannabis-induced psychosis shows more of the mood symptoms, which include depression and anxiety. Cannabis use in adolescents and young adults is consistently associated with the onset and severity of psychotic symptoms and has modest effects on mood and anxiety. Hallucinations and delusions serve as an event or experience that leads to negative symptoms such as low mood, hopelessness, and suicidal thoughts and behaviors. Study results indicate that having both delusions and hallucinations is associated with an increase in the likelihood of having suicidal ideations. Evidence. This study examined 901 patients ages 18 to 64 years old presenting with first-time psychosis to psychiatric services at 11 different sites across Europe over a 5-year time frame. Across the 11 sites, the adjusted incident rates for psychotic disorder were positively correlated with prevalence in controlled participants of use of high-potency cannabis. Compared with non-users, daily cannabis users, particularly high-potency cannabis, is associated with higher rates of psychosis. Research indicates that cannabis use at age 15 was associated with modest increase likelihood of developing psychotic disorder. Treatment plan. Over the past 20 years, early intervention for people at clinical high risk for developing psychosis has become an international priority. PMPs are at a unique position where they can educate patients on abstinence of cannabis and other substances. Abstinence may be the definitive measure to prevent a recurrence of psychotic features. Pharmacotherapeutic interventions include second-generation antipsychotics such as olanzapine and haloperidol, which are the recommended treatment for substance-induced psychosis. Psychotherapy and motivational interviewing are effective agents of treatment as well. Antipsychotics. Olanzapine and haloperidol are equally effective. However, olanzapine has fewer extrapyramidal adverse effects. Risperidone was tried but elicited temporal lobe epilepsy with hallucinations. Valproic sodium was shown to markedly improve psychotic symptoms and cognition. Carbamazepine has been shown to have rapid effects when used as an adjunct to antipsychotics. Abilify has been used in patients who are unable to decrease cannabis use. In conclusion, Mr. Evans has abstained from cannabis and alcohol for 2 years and has been adherent to his second-generation antipsychotic clozapine. Mr. Evans has no hallucinations or delusions, so may be able to wean off his antipsychotic once his mood is stabilized, but will continue at the current dose for now. Since his dysphoria, irritability, and motivation still persist, is it reasonable to start psychotherapy and reevaluate his need to start an antidepressant in the future? The end.